I'm Marvin Mallett, the course director of the Northern New England PNHP Health Policy Internship Program. And we're having three sessions on cost control. And this, uh, two of them on the two primary mainstream approaches toward cost control, one being value-based care, and the other high deductible health plans, often paired with health savings accounts. What we found in those with those strategies, they actually deter needed care in many cases, especially the high deductible plans where patient can't afford it. And with value-based care, uh, you give physicians a disincentive to provide care might that would be expensive and therefore potentially reduce their income. So there's an inherent physician is sort of double agent, where the more care you get, the more the physician loses money. So the question is, can we create systems where we're not making physicians into double agents, and we're not deterring needed care? And my main criterion for developing cost control strategies, or my criteria, one is that the strategy actually has to work. That's important. And that seems to be lacking in the current proposals. The other is that they don't deter needed care. So let's take a look at a few such strategies. And I'll pull up some slides. Okay, so what can or should be done to control healthcare costs? And some of my criteria for an overall strategy is do not rely on only one strategy. No matter how much you like your strategy, don't rely on it. Instead, evaluate every strategy and be ready to modify your program. Modify your strategy, add more strategies. A key one is to be ready to fight entrenched interests who are making money off things the way they are. This is not a game for those who are faint of heart. And and another important strategy, get ideas from the trenches, not the ivory tower. In the trenches, there are people who are working in the hospital or in other facilities every day. They know what's going on in their facility and they can tell you where the waste is. Some administrative job where the person's not doing anything, they know. A fifth uh, point is to don't be hesitant to look at what's happening in other countries. The US is appropriately and widely regarded as having the most dysfunctional system in the world, and we need to end this narcissistic self-absorption and start to look at other countries and how they control their healthcare costs. And finally, uh, this whole struggle is not going to be easy. So fight for every one little 1% you can get out of the healthcare budget. There is no waste that we should not be going after and trying to reduce. So those are the main ideas that I, as a general think approach. There's three general strategies to control health costs. One is price negotiation or price setting by the administrative entity, which we could call the health insurance plan, the public health insurance plan. The second is to try to take costs out of the system. And now, excuse me, the least important is to reduce the volume of services. I de-emphasize that only because that only accounts for 10%, volume only accounts for 10% of the difference in health costs between uh, the other developed countries, which spend half of what we do on average on healthcare. So primarily go for cost. So the higher costs in the US have many potential causes, unnecessary procedures. That's the one that the mainstream strategies go after. maybe they're 5 or 10%. Higher prices for those procedures, a lot more important as a cost driver. We have vastly higher administrative costs in the US, which may account for 12 to 15% of the difference. We have higher prices for drugs, hip prostheses, dialysis, catheters, literally every cost in the system tends to be meaningfully higher in the US. And we have higher malpractice insurance costs. It doesn't amount to that much money, but I think it's a useful strategy. Um, and uh, Hospital administrative costs are vastly higher in the US, and we've discussed this in previous sessions that the countries with single payer systems, Canada and Scotland in particular, have far lower hospital administrative costs. Insurance overhead is vastly higher in the United States, so it's a worthy goal to try to go after that since the other countries don't require nearly this much administrative spending. This graph expresses it in another way. The yellow line is the growth of physicians in 1970 when there were 300,000 or so. And now, in 2017, there were about 850 or 900,000 active physicians. That's the yellow bar. The blue bar are growth in administrative managers. And that really took off during the 1990s to an almost absurd degree with the rise of managed care. And by the way, that last little blip upward on that graph may well reflect the additional administrative costs involved in value-based care, which is a heavily administrative process. So it seems like there are endless numbers of administrative jobs in the U.S. healthcare system, diversion of profit, and all the activities involved in being publicly traded, investor reports, and the like. And in the US healthcare system, everyone seems to get their cut. So we have reinsurance companies insuring our insurers and our self-funded hospitals. And that's just one of many niches in the healthcare system not seen in other developed countries. There are many more. So the most important reform to control cost is to transform ourselves into having a single payer system, often referred to as improved Medicare for all. In a single payer system, the plan is universal. Everyone is in. The big downside for that is that if everyone is in, that means nobody is out. Nobody is out, meaning nobody has no insurance, but also everyone has to be in the same insurance system, meaning they would give up private insurance. And this is key political obstacle. But the point in a single payer system is that everyone is in. If they change jobs, it doesn't matter. If they become sicker or healthier, it doesn't matter. They're all in. Everyone is in. And equally important, the coverage is comprehensive. All necessary medical care is covered. And the other, including everything ranging from drug treatment to physician care to coronary bypass surgery, it's all covered if it's medically necessary care. But the other part of being comprehensive is not just that you have a good benefit package that includes all those things, but the co-payments cannot be at all large. They have to be either non-existent or very small. In Canada and Britain, they have no patient co-payments at all. In uh, France, Taiwan, and many other countries, probably the majority, there are at least some patient co-payments involved, but they're small. And once you have large co-payments, you're deterring care. And if those co-payments are really and co-insurance are meaningful as they are in the US Medicare program, the costs that they are susceptible to experiencing if they get really sick are in the US Medicare program are virtually endless. There's no annual cap, 20% co-insurance on every single cost in Part B Medicare, which is the biggest part of Medicare. So um, you you cannot stop people from buying supplemental insurance. In fact, they should buy it. But if you're now saying that every single medical bill for someone who's covered with supplemental insurance, every medical bill at the doctor's office, even some minor visit, now is going to get sent in two directions. It's going to go to Medicare to cover 80%, and it's going to go to the patient to cover the other 20. So that's incredibly wasteful and expensive. Why not just have a system that's comprehensive, doesn't entail meaningful deductibles and copays, or get rid of them altogether? And we have public financing and single payer systems. There's one public payer funded by taxation. The delivery system could either be in private hands, as it largely is in Canada, or it could be in the public sector. That's otherwise known as the National Health Service. You have that in Spain and England and several other countries. So that can go either way. Again, Taiwan and Canada, private delivery, private sector delivery. In many countries, as I said, public sector delivery. The coverage is portable. You hold on to your coverage when you move or change or lose your job. And it's accountable to the participants. If something isn't working in the system, there has to be a process that forces public officials to attend to those concerns. And this is something that the U.S. tends to lack, both in the private sector. Cigna and United Healthcare are not overly concerned about what you may or may not think of their insurance coverage. And unfortunately, the same is largely true for Medicare. Now, I want to go back to universal and comprehensive, because when a system is covering everyone, it is now in a very strong position to negotiate prices downward. We already said that high prices are the primary difference between the US and other countries. If everyone's in, then you have a larger group of people to cover, and it improves your negotiating position vis-a-vis the drug company, medical supply companies, or other suppliers. Furthermore, um, you're you also have a database to tell you what the healthcare needs in your society are, so you can target your needs and all of your spending can go to where it's most needed. So that's another big advantage. Now, the other reason this works for cost control is potentially a problem, is that if every single dollar that's going into a system is directly translated into taxes to fund them, then there's uh, an incentive to not have adequate services and to try to spend less. And this is a tension that's more noticeable in countries that have single payer systems, though in reality, in the United States, we all pay for everyone's care, either directly or indirectly. So the first strategy is just to have a budget for the system as a whole. Our school system has a budget. Our, fire departments have a budget. Private corporations generally have a budget model for upcoming period of time, and that's something that the U.S. healthcare system lacks. There's no sort of comprehensive notion of what we're going to spend. Now, so let's look at the first set of strategies. Start out with a budget, create a budget. In a single payer system, there's a drastic reduction in administrative costs. And in the United States, you're brought up to believe the opposite, that what makes things efficient is putting them in the private sector, and government is inevitably inefficient. But this is not the case. And if you think about who benefits from that belief, you don't have to think hard to realize that those who wish to privatize the school system and the healthcare system and the VA and many other services, jails and prisons, is now being subcontracted. Those who support that are often benefiting from it financially. So if you look at other countries with single payer systems, there are much smaller numbers of administrators, and those administrators in those other countries are not more talented or intelligent than our administrators. In other words, it's not an inherent part of intelligence. Extra intelligence is not needed to create an efficient healthcare system and make it operate well. You just have to have a proper system design. And when you're designing in multiple insurance companies, you inherently have more administrative workers. So we, if we have a government system, it will inherently be less bureaucratic. Um, so one of the best barometers for the extent to which you've reduced administrative cost is to ask the billing clerks or the billing staff in a hospital or in a provider's office, ask them how many payers they're dealing with. And if that number is one, then it's a single payer system. If it's multiples and higher numbers, then it's probably not a single payer system. There are other insurance companies and they have to contend potentially with different rules and payment schemes for each one. So that's a good barometer of what's going on. Um, Another is to eliminate reinsurance and other diversions of money out of the healthcare system. Another cost that's never not factored in that you're saving a lot of money on with single payer healthcare is the personnel or human resources departments in every business in the country that's trying to provide health coverage has an employee or two or more that's focusing on how to get their employees coverage. That's waste. That goes with a single payer system. It also gets business off the hook of having to worry about healthcare, which is an enormous headache for many or even most businesses that try to provide coverage, since there's no cost control effectively in the United States. Another advantage of a single payer system is it gives you a comprehensive database. So the value-based care systems are worried about doctors that are aberrant and ordering too many tests. Well, with a comprehensive database that includes all the care in the country, it's much easier to detect variations in care. So, for example, let's say that the average number of visits per day of primary care doctors in your community is, say it's 16 or 18 or whatever. But then there's a 0.5% of doctors who are seeing more than 50 patients per day, and there's one that's seeing 95 patients per day. Now, when you have multiple insurance companies, there's no way to know that. But with a comprehensive database, you can discover what would appear to be fraud for that particular provider of care. And other possibilities that you might detect incompetence. So if one if one urologist is performing prostatectomy at a much higher rate than all the others, not for cancer, but just for benign conditions, it may be fraud, but it might be incompetence and it's certainly a variation in care. And you could begin to have a plan developed for meaningful variation in care. Simply sharing the data by itself might well be useful and give that urologist something to think about. Um, Another is to plan to match technology with your country's or your state's healthcare needs. So if there's one community that has particularly high intensity of opioid abuse, you could make sure that there's adequate treatment facilities in that neighborhood. If there's some other community that doesn't have that healthcare need, you may not need that much technology. Furthermore, in the United States, we tend to have huge numbers of MRI scanners in wealthy communities, and often they're underutilized, but the reimbursement system funds them so well that the MRI scanners proliferate. It's not only the scanner, there has to be a highly trained technician to run the scanner. So all of that offers a possibility for efficiency in your healthcare system when matching the dispersion of technology with the needs of the various communities you're serving. Okay, and then finally, the health system can be designed to improve public health, making sure that there's vaccines available. If you're talking about a rural community that, let's say, the veterinary service and the veterinarians in your community report a lot of rabies or high prevalence of rabies in the predator population, you could make sure that there's rabies vaccine available. You could make sure that people are properly vaccinated, you can make sure that cancer screening is happening the way it's happening as it should, and you can have a healthcare system where the fees involved, if there are any, are designed to um, motivate people to adopt healthy lifestyle ranging from exercise. You could have alcohol and substance abuse treatment available. Um, and anyway, so these are the services that can improve public health, and many of them, some of them at least, can save money, particularly prenatal care, pediatric vaccination, and similar interventions. Okay, another strategy is to put an end to privatization, which tends to siphon off a lot of funds into uh, profit and especially if there's stockholders involved or private equity, capital control, you tend to have a tremendous diversion of funds to owners or wasteful administrative costs. So eliminating publicly traded for-profit entities to the extent that it maybe often will be a useful strategy. They typically have high CEO salaries. They have to divert what should be healthcare money over to investor relations, dividends, and profit. And put an end to the privatization of Medicare, Medicaid, and other public health programs. Eliminate advertising, which serves no useful purpose. You probably should have health education going on, but it ought to be based on what public health issues in your community and provide information about those. Lobbying is not useful. It's again diverting healthcare money. Pharmaceutical industry is especially notorious for spending amazing amounts of money on lobbying, which we all then pay for in the form of higher drug prices. 2 out of 3 people disapprove of the job Congress is doing, and who's the third person? Of course, the third person is a lobbyist who's got a very well-paying job and the company that employs him. Very invested. And you get the feeling, so many people say, oh, the US has a dysfunctional system. And people who can't get health care certainly feel that way. But not everybody feels that way. There are some companies, many of these profitable companies, ranging from United Healthcare to Eli Lilly to other for-profit entities, they're happy with the system just the way it is. And their lobbyists are there primarily to keep it that way. Okay, so cost control, payment reform. How can you pay doctors and hospitals? So in this internship, we just had a very fine talk by Dr. Adam Gaffney on exclusively focused on payment for hospitals and it, eliminating in these payment systems, you can try to eliminate procedural bias with provider reimbursement strategies that don't reward very high cost procedures, which is a feature of the current US healthcare system. And you don't even need a single payer system for that. You could simply change the fee scale and reimburse for procedures that are just grossly deviant from other countries, reimburse them at a lesser rate. And then some services are under reimbursed in the US, primary care, mental health. You could improve that reimbursement. That intervention alone, which doesn't actually require single payer reform, could help a lot. It would require some government involvement, though, to facilitate that if you're going to retain all these health insurers. So, and what Adam Gaffney, Dr. Gaffney described was having separating the decisions and the payment for capital improvements. In other words, big ticket items ranging from MRI scanners to siting a new hospital and siting a new mental health facility or nursing home. These should be based on community need and thereby allow you to match your service siting with the needs in communities. And on the other hand, it makes it so that the hospital can have a budget for operating costs, not have to accumulate extra money to fund capital expenditures. They can just focus on their operating costs, and that would be subject to an annual negotiation between the health insurance fund and the various hospitals, primarily based on their previous year's budget, what cost of living is in the community, and if they've added additional services, then they likely need higher operating costs to account for that. And it sounds like this would lead to a lot of conflict, but it works out in the countries that, in fact, use annual negotiations for to determine hospital operating costs. Um, and let me move along. Here's another huge source of waste in the United States, our system of electronic health records. And the the cartoon figure on the left does not express the kind of frustrations that most health workers, especially nurses and doctors, feel about their health records they're using. Um, Now, outside the VA system, where everybody can easily communicate with everyone else, virtually no hospital or practice that's not owned by a single vertically integrated system, none of them pretty much share information electronically with practices that aren't within the same system. This leads to delayed diagnosis, misdiagnosis, ordering the wrong test, repeating tests that have already been done. So here you have the worst of all worlds. You have misdiagnosis or delayed diagnoses because you don't know what's already happened, because you don't have ready access to that record. You're relying on the decisions of a receptionist somewhere who's going to fax records to you, which is still the big way of sharing records in the United States. So your misdiagnosis is an issue, and it's much more costly. When everyone can just log into the same system, it's far more efficient. And by the way, it got this way when there was a government requirement that uh, with initially extra payments for adopting electronic health records at the point where this country was transitioning from paper records to electronic health records, which was happened mostly during the first decade of this century. And there were incentives to adopt, and later on there were penalties for not adopting, and it was done over a 4-year period. Well, the government didn't say, here's a software system. They said, good luck, go find one. So private sector companies wanted to get themselves established with as many doctors as possible, as quickly as possible. So, because everyone involved knew that to change from one entire electronic health record system to another was going to be hugely expensive. So they all rushed products to market without proper uh, trialing and focus groups and user communities that would complain about it. None of that happened. Instead, they had to rush products to market, get a foothold in as many practices as they could, leading to no communication among any of these practices and uh, terrible quality software. This is what we're plagued with through poor government policy that in the first decade of the century proved to be ultimately bipartisan. Anyway, so how do we get out of Babel? And the federal government should take the time. If it takes 5 years or even 10, they should do it, develop a high quality electronic health record system, get it piloted properly so that Nurses and doctors and other health physical therapists, other healthcare workers could pilot it, try it out, complain about it, and then get it implemented free of charge to every doctor's office in the country and every hospital, and link it up to everyone else. And this would save huge amounts of money due to the miscommunications, the low quality, and the annual licensing fees, which in the case of these larger systems that are beginning to become dominant, the annual licensing that the healthcare facilities have to pay these companies is huge, needless, leading to huge profits. These companies are publicly traded on Wall Street. Oracle is one of the big ones. Just all this money going to investors rather than healthcare money going to healthcare. So, hire t talented software developers, teams of providers, and take as long as takes work on it to make something people will be happy with. Okay, then there's pharmaceutical industry related strategies. Here in the US, we spend the most on drugs. We have very high drug use per capita, and I'm talking about legal prescription drugs, not just illegal ones. And there's an array of strategies that we will cover on later on in this internship, and so I won't get into this in detail at this point, but primarily it depends on government evaluating which drugs are the most useful and then using the negotiating power of a single payer system to negotiate prices downward. Uh, and we'll move on. Another set of strategies, reforming the education of health professionals. First of all, we should plan our education process in relation to anticipated needs of the future, of health needs of the state or country in the future. So if we know we have an insufficient primary care labor force, you would put more money into training people, providers in the fields of primary care. You could have it if you know that rural areas have weaker, have fewer providers, weaker provider healthcare provider systems and fewer practices. You could create incentives related to geography. So in other words, you could forgive medical school tuition or cut off or reduce it greatly for providers who are willing to serve in underserved communities or urban areas or rural areas that are underserved. You could have a workforce training plan that includes a plan to care for high needs communities, recruiting, making sure that you have trainees who are coming from those communities because people tend to migrate back to communities at or similar to where they were brought up. And this may, in fact, require uh, affirmative action and other kinds of strategies so that communities of color or linguistic minorities have physicians that there will be in a stronger position to provide care. There's been a lot of research showing that among Black communities in the United States, um, Black patients tend to follow the advice of Black physicians at a higher rate. And it seems like no matter how hard other physician groups may try, that Black physicians are able to ensure adherence to treatment plans. So we may need to, I think we do need to consider that in workforce planning for the future. Another issue is it actually helpful for medical students and other healthcare profession students to carry huge debt loads that may distort their decision making about where to work subsequently. They may take the highest paying job rather than the job that would help the community the most or that they're just more interested in. And then how should education be funded? Right now, there's a very complicated funding scheme, not primarily through tuition. And the question is how that could be thought through so that we end up with the best outcomes. Now, what about staffing issues? Especially rural hospitals, but many hospitals, all hospitals will have turnover in their employee groups for all the obvious reasons. Employee could die or retire. or family may move. So, how do we replace, how do we fill staffing vacancies? And as is the case in many of these other areas, the US tends to use the most costly system you could possibly conjure up. Here we have the medical staffing sector, and multiple for-profit companies are competing, all of them with something like 25% profit rates, very high markups. And for short term, like vacation coverage, or you suddenly lose an employee, there's nearly 80 to 100% markup. So in other words, these staffing firms find doctors and they find nurses, and let's say they pay the nurses, uh, their pay is $50,000 a year. Say it's $50,000 a year for sake of argument. That company is not getting 50,000, the equivalent of $50,000 a year. The hospital is paying this company 80 or 90,000 a year. So the company retains the rest of that money. That's healthcare money now being diverted. And for permanent positions, in primary care and in my specialty, hospital medicine, there are often finder's fees. And this is 6-year-old data, but now they're up from $40,000. You just pay the firm $40,000 to find you a doctor. And now it's higher, much higher in certain specialties like orthopedics. So, and all they have to do is if they hire someone who stays in the position for a couple of years, they get the money. So the question is, can we come up with a system that's more efficient? So what we could do is say each state or even the federal government could create a website, say healthcarejobs.gov, promote its existence nationally so that every trainee who's just completing their training or about to complete their training knew about this website, could get on it, and it would be an organized website where if you're looking for a temporary position, you could click on temporary versus long term. And if it would be divided up by specialty. If you're interested in a rural setting, it could divide things up by rural versus suburban versus urban. It could be by a compensation model. If you wanted to work in a prepaid practice like Kaiser, you could click on that. So, and geographically, obviously, and by specialty, all of these could be done. And if everyone knew about that website, you would then, and let's say you're interested in living in Maine. You could click on Maine in the website. You could click right in, type in your specialty, and then you'd see every single job in the state. And it wouldn't depend on which hospital hired which company who's got staffing that's trying to get those positions filled. But you may not find out about all the positions unless you sit down and call every single hospital, which would be viewed as kind of weird and it would be time consuming. So instead, you could go to this website and get it done quickly. And the website wouldn't even cost that much once it's in operation. It could get done quickly. And to fill staff needs quickly, you could have an urgent section and maybe say that, there'll be higher payments for urgent, urgent staffing needs. You could even hire staff to work on urgent healthcare needs that would be linked up to every single job in the country that's available. So so here you're fighting a private sector that has many companies. There may be as many as 80 or 100 companies. And what they do is they send out one email and text message after another, one after the next. I get them from all kinds of companies for parts of the country I've never in my life wanted to live at, but doesn't cost anything to send a test message. So they get my name in some database and they're blasting out these messages and it's taking up my phone and it's becoming time consuming to delete them all. And this is what goes on in this sector of the economy. Again, you could provide loan forgiveness to promote trainee selection of critical specialties and to work in underserved areas. and build in an ability to deal with urgent staffing needs and public health crises as well. Okay, so really, all of these strategies are trying to get the system to spend healthcare money on healthcare, not other things. So there needs to be a reduction, stop diverting funds to the malpractice liability system. That by itself eats up about 1% of overall healthcare costs. Think there's a strong argument to be made that it does not improve the quality of healthcare. No, I have never met a doctor who said, I really want to make 3 or 4 mistakes this day, and think about which patient I want to do that to. This does not happen. And if you have an electronic health record that includes every patient in the country, that by itself would greatly improve the quality of care, especially if it's high quality software. And you could link that to information systems. Like, for example, you could have a system that said your patient has lab results in a certain pattern. These 7 or 8 labs are abnormal in a certain way. This other one is normal. So please consider the following diagnoses. And you can improve quality that way rather than creating an inefficient system that's diverting an entire percent of healthcare money over to liability. Of course, having a single payer system would reduce the quantity of the rewards, but the whole system is simply a waste of money. Wasting money for our court system and could be handled in a very different way, some sort of adjudication for complaints, and rather than this more costly system that is unpleasant for doctors to function in and is wasting healthcare money. And for those of you who are activists for single payer reform, you have to remember that you've got the pharmaceutical industry is going to oppose single payer reform. You've got the insurance industry, which will be eradicated if we have single payer reform for the most part. You've got many other companies that are profiting greatly from the system just the way it is. So the one group that has more meaningful financial resources than most other groups, such as maintenance workers or nurses, doctors do have more lobbying power and money to spend on lobbyists and organizations. And you want to have the one group that has more relatively higher funding available. You want to bring them into this struggle. Doctors will benefit from single payer reform. It'll be easier to practice. All this prior authorization nightmare stuff would go away. So it's very important intervention to support very major malpractice liability system reform. It's not helping anything. Finally, there is a lot of duplicative regulation. And as I was saying earlier, the public sector in the United States is constantly criticized. It's built into our educational system almost to assume government will have gratuitous amounts of regulation. In the healthcare system, we have a lot that's actually in the private sector, like the inspection systems for the hospital are heavily privatized. Either way, I think we should look at the healthcare system and try to get the amount of inspection and regulating right, instead of just constantly adding on and never questioning regulations we already have. This is a system that has to be dynamic, accountable. You can't just create regulations, keep them indefinitely, and add more on later. It's got to be looked at and reevaluated and simplified to the extent possible. This is a big responsibility to put on those of you who will administer healthcare in future years, but this needs to be your model. Be flexible, be accountable, solicit feedback, and be ready to change. Okay, so that's the talk for today. Thank you all for your attention.